Good day. I am Dr. Andrea Cristina Baliton-Veliganio, and I will be giving you a lecture on operative obstetrics. I am a practicing obstetrician gynecologist here in Davao City, and I had my residency training in Southern Philippines Medical Center. This is my topic outline. We will be discussing today about operative obstetrics, breech delivery, assisted vaginal delivery, forceps and vacuum delivery, and cesarean delivery. But before we go into the detail, let us review first about fetal positions and fetal lie. When we talk about fetal lie, it is the position of the fetus in relation with respect to the birth canal. Okay, at the onset of labor, the position of the fetus with respect to the birth canal is very critical to the route of delivery and thus should be determined early on during prenatal and before the onset of labor. So there are 99% of labors at term. The fetal lie is longitudinal. Of course, we have other different types of lie, which are transverse lie and an oblique lie. So this is a longitudinal lie, an oblique lie, and a transverse lie. Fetal attitude. A fetal attitude assumes a characteristic posture, whether the head is flexed, the head is deflected, or in a vertex position, or extended in the form of a face presentation. Abnormal exceptions to this attitude when the head is progressively extended in the face presentation. As a rule, the fetus forms an ovoid mass that corresponds roughly to the shape of the uterine cavity. Abnormal exceptions I mentioned earlier is a face presentation, wherein the head is very extended. This would result in a hyperextended head, wherein the vertebral column could be impinged. Then we have fetal presentation. This can be usually felt when you do a vaginal examination and internal examination when the patient cervix is already dilating. It is the portion of the fetal body that is either foremost within the birth canal or in closest proximity to the birth canal. So this is an example of a cephalic presentation, a longitudinal lie, but it is a breech presentation, and a transverse lie wherein the shoulder would be presenting. So the fetal presentation could either be a breech or a cephalic presentation and a shoulder or transverse lie presentation. Fetal position. It is a relationship of an arbitrarily chosen portion of the fetal presenting part to the right or to the left of the birth canal, or to the right or to the left of the mother. Okay, not your left, not your right, but the mother's right and left. Whether it is a cephalic presentation, is it a right occiput presentation, position, or a left occiput position. If it is the breech, or reference point would be the sacrum. Okay, it would be the sacrum. Is it right occiput, right posterior position of the sacrum, or is it anteriorly located, the sacrum? Okay, on an oblique lie or a transverse lie. So the reference point for the transverse lie would be the acromion process for the shoulder area. So let us now discuss operative obstetrics. Let's start with the breech. We have different kinds of breech. We have a frank breech wherein the lower extremities are flexed at the hips and extended at the knees. That is what we call a frank breech. Thus, we cannot feel the feet cannot be felt on the cervix. Instead, what we feel during internal examination are the ischial tuberosities of the fetal sacrum. We also have complete breech, wherein both hips are flexed and one or both knees are also flexed. Okay, so when you talk about complete breech, Both hips are flexed and the knees are also flexed. You may feel the feet and along with the buttocks with this kind of bridge when you do internal examination. We also have a incomplete bridge. One or more or both hips are extended. One or both hips are extended. And so what we feel with this kind of bridge are both feet or one of the foot. Okay, this is what we call an incomplete bridge. Okay. Next, what are the associated factors resulting to a breech presentation? It could be hydramnios, polyhydramnios in particular. Okay. Multifetal gestation can result to a breech presentation. Hydrocephalus can also result to a breech presentation. Anencephaly, absence of fetal cranium, can also result to a breech presentation. Structural uterine abnormalities, it could be a Mullerian anomaly or a presence of myoma, which will result to a breech presentation. Aprevia can also result to a breech presentation. Other pelvic tumors, ovarian new growth, myoma uteri, can also result to a breech presentation. Or associated prior breech delivery. It says that there's 10% of delivering or having a breech presentation in the second pregnancy and 28% chances of having another breech on the third pregnancy. What are the associated complications when you talk about breech? When you have a case of a breech, you might encounter cord prolapse. You might, because there's breech, there might be placenta previa. There might be congenital anomalies. There might be uterine anomalies. And so you will have difficulty with delivery. And there would be increased maternal and perinatal mortality and morbidity with breech presentation. So how do we deliver breech? A breech could be delivered vaginally and a breech could be delivered via cesarean section. Let's talk about first with the methods of a vaginal delivery. We have different kinds. Spontaneous breech delivery. We also have a partial breech extraction and a complete or a total breech extraction. If you consider vaginal delivery for a breech, you should know the fetal size. Okay, the degree of the neck flexion or the extension of the neck is evaluated. In the olden times, we used to have X-ray pelvimetry in order for us to see the fetal structure, how extended or how flexed the head is. And you have to know pelvic dimensions. You have to know the pelvimetry. The pelvimetry must be adequate for you to actually deliver a breech. Okay? So that you should be able to assess for a cephalopelvic disproportion, because if you deliver a breech and there is cephalopelvic disproportion, you might not be able to deliver the aftercoming head. All right? So how do we manage breech? We have three options: vaginal breech delivery, external cephalic version, and of course the cesarean section. If you opt to do the vaginal delivery, we have first the spontaneous breech delivery. When you do this, let me remind you that this is only done by a skilled obstetrician. It cannot be done and you see something and you see one and you do one. You have to be very trained in doing this procedure because you might incur injury on the baby and the mother. So let us first start with a spontaneous breech delivery. The fetus is expelled spontaneously without traction, without you giving traction or doing traction or manipulation. This is usually possible for a very small fetus. And like, for example, if it is in a breech presentation, but it's a relatively small fetus, then it can just be delivered spontaneously with the help of very strong maternal expulsion efforts. We also have partial breech extraction. What is partial breech extraction? The fetus is expelled spontaneously with the maternal expulsive efforts, no, expulsive efforts until the level of the umbilicus of the baby. Okay, and then the remainder of the body from the umbilicus up to the head is being delivered by the operator by employing traction. And then there are certain maneuvers. That's why a breech delivery should only be done by a skilled professional, a skilled obstetrician, because there are maneuvers, there are certain movements that has to be done properly in order to deliver the breech safely. No? So we also have a complete or a total breech extraction, wherein the entire body of the fetus is extracted by the obstetrician. This is often true for the delivery of the second twin, especially if it is in a transverse position or in a breech presentation. Now we do, after the delivery of the first of twin, which was in a cephalic presentation, then we actually do a total breech extraction for the second twin. If you do this, again, the operator should be skilled. There should be somebody to assist you, the nurse, the midwife to assist you in doing the procedure. Analgesia must be given because this is a rather painful procedure so that the mother will be able to cooperate if there would be less pain. And then there should be a pediatrician or the pedia team should be ready once the baby is delivered, because again, you might encounter difficulty of delivering of the baby and resuscitation might be needed. And so if you do this, the pediatrician and the team, the neonatologist should be there to catch the baby once the baby is delivered. What are the contraindications for a breech? A cord presentation. You cannot deliver a breech if there is cord presentation. A footling presentation could when you be able to deliver one leg, but the other leg you cannot maneuver. Also, a cord presentation or a cord prolapse may also happen for cases of footling breech. A hyperextended fetal head. Okay, a clinically inadequate pelvis, you cannot really deliver a breech by a breech. And so those primiparas delivering for the first time, having a breech baby, breech presentation, they cannot deliver vaginally because we haven't tested the passage yet. And you might not be able to deliver the aftercoming head. Okay, so in cases it is contraindicated for fetal anomaly, hydrocephalus, gastroschisis, sacrococcygeal teratoma, you cannot deliver this via breech or even in a vaginal delivery. Fetal macrosomia, the fetus is big. Even if you have an adequate pelvis, but then the fetus is really big. So you might be having dystocia and you might, instead of delivering a live baby, you might cause fetal death. Or fetal growth restriction. Why fetal growth? This is small. But then patients or babies who are fetal growth restricted have disproportionate body dimensions, no diameter. So you might be able to deliver part of the baby, but then the head or the abdomen might be, you might be having difficulty in delivery. So the technique in delivering the breech, again, you do not pull on the breech. There should be adequate maternal expulsive effort. There must be anesthesia. You may do an episiotomy if deemed necessary, but it is not a routine that you do episiotomy. And then there must be a maneuver that you should do in order to deliver the leg and the arms. So these are the maneuvers. The Pinard's maneuver in delivering the fetal leg. Procedure involves manipulation to deliver the leg. 2 fingers of the provider's left hand are placed beneath the parallel to the femur. Okay, and then the thigh is then abducted. And the popliteal fossa should induce knee flexion. Once you have reached the foot is grabbed. The foot is grabbed gently, and the same is done on the other leg. All right. Once you have delivered the leg, the thumbs are then placed over the sacrum. Okay, the fetal bony pelvis is grasped with both hands. Both fingers should rest on the anterior superior iliac crest. Okay, and then it should be on the sacrum, and you should not be pulling on the bridge. There should just be gentle traction, but in order to deliver the bridge at this point, there should be adequate maternal expulsive efforts. Okay, you do this until you have seen the scapula. If there's already winging of the scapula visible, the trunk is rotated, the body is rotated clockwise or counterclockwise to bring about the delivery of the anterior shoulder. Okay, the fingers and the hand are aligned parallel to the humerus. So at this point, if the operator is not very skilled, you might incur fracture on the humerus. Okay, so the body of the fetus is rotated at 180 degrees and in the reverse direction in order for you to deliver the other shoulder. Once the shoulder is delivered, now we deliver the aftercoming head. This is the Morisu maneuver. Okay, the index and the middle finger of the hand of the operator is placed on the maxillary area and pressure is applied in order to maintain flexion of the head. And look at the picture here. That's why you need an assistant because someone must be pushing, steady, pushing on the hypogastric area and the suprapubic area in order to help in maintaining the flexion of the head. Okay, so the rest of the fetal body is resting on the palm and the hand and the forearm of the operator, the non-dominant hand. It's seen hanging, no? So pressure is applied on the maxillary area. Someone is pushing on the suprapubic area. And the fetal body is lying on the hand and the forearm of the operator. Sometimes we also use Piper. It's not other forceps, kind of forceps, but rather we use a Piper forceps. A Piper forceps is used to help you deliver the aftercoming head. There should be proper placement of this forceps in order for you to aid in the delivery of the aftercoming head. What if the head is being entrapped? You have delivered the body, you have delivered the shoulder, but then the head you cannot deliver. What are the instances that this happens? Probably the cervix is not fully dilated. All right, the bag of water was just bulging, but then when the bag of water is ruptured, the cervix is not really fully dilated. Okay, so or maybe there is a palopelvic disproportion. That's why you do not really risk a primary, a primi and a breech because you haven't tested the pelvis yet. You might be able to deliver the body, but then you will not be able to deliver the head. What if the cervix was not really fully dilated and the head was entrapped? You can do a dorsal incision. You excise, you cut the cervix at the 6, 10, 6, 10, and 2 o'clock position in order to release the aftercoming head. And you just suture the incisions right after. It is in this position at the 6, 10, and 2 o'clock position because this is the area wherein it is less vascularized. Again, please take note that your decision regarding the mode of delivery should be depending on the experience of the healthcare provider. If you are not skilled to do the delivery, then you must not consider delivering the baby via vaginal delivery if it is a breech presentation. Okay, so what are the factors that would lead you to delivering the fetus in breech presentation via cesarean section? you are not a skilled operator, or no one is a skilled operator in delivering a vaginal breech, then you must recommend cesarean section or do cesarean section. Patient's request, patient does not consent. No? The patient does not consent for a vaginal delivery. Then you must resort to a cesarean delivery. You have a very large fetus. Of course, they must not be delivered via vaginal route. Okay? A viable preterm fetus with active labor or with indicative delivery. Remember, please take note that usually preterm fetuses have this disproportion. They tend to have bigger heads. They tend to have larger heads. And so you cannot really risk delivering a preterm baby and a breech via vaginal route. Okay, fetal growth restriction. Remember that they have disproportionate body parts. The head and the abdomen are not proportionate. It tends to be bigger. And so you cannot risk a vaginal delivery and a breech. Fetal anomaly, as mentioned earlier, sacrococcygeal teratoma, gastric schisis, hydrocephalus, you cannot deliver. An incomplete breech has to be delivered via cesarean section. A hyperextended head, you saw in the ultrasound, you saw in the X-ray pelvimetry that the head is hyperextended, then you cannot do vaginal delivery and you should do cesarean section. The pelvis is inadequate, contracted pelvis, the fetus cannot pass through, or the patient had a prior cesarean section. How about external podalic version? The fetus is turned in utero from a non-cephalic to a cephalic presentation by manipulation of the maternal abdomen on the outside. But there are prerequisites. It is part of the training of every obstetrician to do external cephalic version, but there are prerequisites to this. Okay, it must be just a singleton pregnancy. The gestation should be more than 34 weeks. There are no contraindications to labor. You have established that the fetal well-being is secured. No, the heartbeat is normal. The movement, the tone. No, you did a biophysical testing before the procedure. You did an ultrasound. Okay. What else? The amniotic fluid volume is adequate. Okay, there is an available ultrasound machine. You know the position of the fetus. And the facility, it should be a double setup. The facility, should there be a need to do a cesarean section, then you have to do external podalic version in a facility that has an operating room. Should there be an indication for immediate delivery, then it should be readily available. Absolute contraindication, placenta previa. You cannot do manipulation. Abnormal fetal heartbeat, compromised fetus. There is active vaginal infection in the form of herpes, genital herpes. You cannot deliver vaginally. A previous classical incision, a myomectomy, a previous uterine surgery, you cannot do external podalic version. And then absolute contraindication could also be hemorrhage, some major fetal anomalies, multiple gestation, you cannot do external podalic version, or when the membranes are already ruptured. Other relative contraindications is oligohydramnios, the head is hyperextended, probably you can manipulate. You had 2 or more previous cesarean section, is only a relative contraindication. The patient is morbidly obese, can just be a relative contraindication. The patient is already in labor. Remember, when there are contractions already, the uterus is hard, and so you cannot actually manipulate. That's why we do the external podalic version prior to term, no? More than 34 weeks, you more or less have an almost term baby, but the patient should not be in labor. Uterine malformations, Mullerian anomaly is just a relative contraindication, and fetal anomaly, it depends. So that's why there has to be an ultrasound when you do this procedure. What are the risks if you do external podalic version? you might incur placental abruption, premature separation of a normally implanted placenta, that is placental abruption. You might rupture the bag of water. You might initiate labor. You might incur non-reassuring fetal heart rate pattern. You might compromise the baby when you're doing it. And you might also incur fetal and maternal hemorrhage. Let's talk about assisted vaginal delivery. Assisted vaginal delivery comes in the form of using a vacuum and a forceps. So an assisted vaginal delivery is in the use of a vacuum or a forceps to achieve vaginal delivery and hasten delivery in the second stage of labor. From second stage of labor, from full dilatation to the delivery of the fetus. Okay, so there are different types of forceps delivery, but then what is done nowadays, we don't do any more low and mid forceps. We only do outlet forceps. What is an outlet forceps? The scalp is visible at the introitus with a separating the labia, meaning it's already crowning. The fetal skull has reached the pelvic floor. It is crowning. The fetal head is at or on the perineum, therefore it is crowning. Okay, the head is in the occiput anterior. The occiput is in the anterior of the mother, or occiput posterior. Or the head is at the left occiput anterior, or the rotation should be less than 49 degrees. Okay, we only do outlet forceps, no more low and mid forceps. Okay. So what are the prerequisites? The head should be engaged. It should be crowning. It should be there already. The vertex presentation. The head should be in a vertex presentation. You know the fetal head present position, but sometimes this could be difficult, especially if there's already kaput. Now the patient has been in labor for quite a long time. CPD is not suspected. The fetal weight you have already estimated. Again, the operator should be experienced. At this time, the membrane should be ruptured. The cervix should be fully dilated. There should be adequate anesthesia. Remember to empty the bladder because it will impede the delivery of the head. No fetal coagulopathy because you will be using a vacuum or a forceps, and you might incur fetal injury. Okay, willingness to abandon the procedure. Okay, and there should be patient's consent, informed consent that you are doing this to the mother in order to deliver her baby. Okay, criteria. Let's talk about first the forceps. What are the indication in using this and the vacuum and the forceps? The head is already there, but then there's already, you have noted that's already fetal bradycardia or non-reassuring the heart, there's bradycardia or tachycardia, you have to expedite. And so since the head is already there, then you have to expedite, and you needed to use a vacuum or a forceps, whichever is available, in order to deliver the baby as soon as possible. Okay, maternal medical conditions wherein they should not be doing Valsalva. They cannot do Valsalva in cases of cerebrovascular disease, thyroid disease, cardiac disease, because the expulsion, maternal expulsive pressure can worsen their condition. Then we can employ the use of an assisted vaginal delivery in the form of forceps or vacuum. Okay, the mother's already exhausted. The head is already there, but the mother's already exhausted. Then you can use this with the patient's consent. Okay, and should there be failure in using these methods, then you must do a cesarean section. Or if during cesarean section you have difficulty delivering the head is floating, okay, then you can use a forceps and a vacuum also. It's not just used in vaginal delivery, but sometimes during cesarean section, obstetricians have difficulty delivering the head, and so we use a vacuum or a forceps. What are the contraindications? You cannot do any of this. You cannot use vacuum or forceps if it is a brow or a face presentation. You cannot. Okay? You do not know the fetal position. You have a fetal condition like bleeding disorders for the baby. You cannot do. Okay? The baby is less than 34 weeks. So it is a preterm baby. So it is contraindicated. When you do this, when you use this, it should be on a term baby. Let us discuss first the forceps. But before that, let us review fetal head anatomy. This is the anterior fontanelle, the posterior fontanelle, and of course the sagittal suture, the suboccipitobregmatic dimension, and the occipitoparietal dimension, and then the occipitofrontal dimension. These are the dimensions or the areas of the head that you have to be familiar with. Forceps. Okay, so the forceps has different parts. The cephalic curve and the pelvic curve. With the parts of the forceps, it has the blade. This is the shank, and it has a handle. So we have different kinds of forceps. Remember earlier when we were talking about breech, we have the Piper forceps that we use in delivering of the aftercoming head in a breech delivery. So other forceps available are the Simpson, the Elliott, the Keelan forceps. We have the Tucker-McLean forceps, the Bailey-Williamson forceps, and the seldom used is the Barton forceps and traction hand, which is a traction handle. Okay, so commonly used are the Simpson and the Elliott forceps in vaginal forceps delivery. The Piper forceps, remember that this is used for the vaginal breech delivery of the aftercoming head. Okay, blade application and delivery is very important. Okay, the handle of the left branch is grasped. Okay, between the thumb and two fingers of the left hand. Okay, left handle, left hand. So again, this must be done by a skilled operator. Okay, the forceps application is checked in 3 ways. Position and safety. Posterior fontanelle should be visualized, it should be identified. The fenestration of the forceps must be felt, and the sagittal suture should be identified. Okay, this is how we apply the blade. And this should, when the blade is properly applied, this is how it would look like, no, on the fetus. Okay. The forceps should be symmetrically placed, okay, and articulated, meaning the forceps will lock. If you cannot lock the forceps, it might be placed wrongly. No? Do not force to lock the forceps. If you cannot lock the forceps, meaning it is malpositioned or it is placed improperly, and it might be in this position, and you will cause injury to the baby or to the mother also. How about vacuum extractor? In the past, we used to have this kind of vacuum, no? Wherein the pressure is coming from a machine, and then the operator will step on the gauge in order to increase the pressure, and the cup used to be stainless. No, so this can cause more injury to the fetus. Now we have this, no, the Kiwi Omni cup, and we also have this one, the Mitivac Mystic 2, no, the Mitivac soft bell cup. But what is common in our country is the Kiwi Omni cup, wherein the pressure is being given up to this level. There is a gauge. You only give pressure up to the red mark, And then the vacuum or the cup is applied on the fetal head. Okay, how do we place the cup properly? Okay, it must be over the flexion point. Where is the flexion point? Okay, it should be, the cup usually measures 5 to 6 centimeters. Okay, the flexion point is found along the sagittal suture, That's why you should be able to identify the suture. It is 3 centimeter in front of the posterior fontanelle, 3 centimeter from the posterior fontanelle, and 6 centimeter from the anterior fontanelle. Okay, so this is it should be placed on the flexion point. There are wrong placement, no? Incorrect cup placement. Sometimes they tend to put it near the posterior fontanelle. It is on the anterior fontanelle. Sometimes it is lateral to the sagittal suture. If this is so, then it might worsen a synclitism. No, the fetal head will not be able to rotate if it is not placed properly on the flexion point. And you must be avoiding the anterior fontanelle because it will cause pressure to the brain. Okay, so we have a mnemonic when you do vaginal vacuum extraction or also with forceps. Okay, there should be anesthesia. You have your assistants. Okay, you have to secure consent. Okay, and then you have to be no contraindication. What contraindication? Cephalopelvic disproportion, active genital lesions, and as mentioned earlier, fetal macrosomia, among others. Okay. B, the bladder should be empty, or you should have a backup plan. If this does not work, then you have to do cesarean section. C, the cervix should be fully dilated, fully effaced, and you should be having adequate uterine contractions because we have to also have assistance from the mother when you do the vacuum or the forceps delivery. You should know if there is no dystocia. You should know the fetal position in order, and you should be sure that there's adequate pelvis in order for you to deliver the baby vaginally using the vacuum and the forceps. Equipment, you should have an electronic fetal monitor in order for you to check from time to time the fetal status. Okay, when you use your forceps, there should be, you try to do phantom application. You haven't inserted the blade yet, but you try to position the vacuum externally, no? Phantom application, you imagine before actually inserting the forceps. The fontanelle, you should be able to identify the flexion point. With vacuum, you should ensure, all right, with vacuum, you should ensure that there are no maternal tissues, no vaginal tissues that are entrapped in the cup, because when you pull it out, you will cause trauma to the vagina if it has been between the head and the cup. So there should be no maternal tissue. You sweep around the cup and check if there are maternal tissues attached or entrapped or around the cup. And then with forceps, you check application, the posterior fontanelle located midway between the blades and 1 finger breadth above the shank. Okay, and you should know the distance of the forceps of the blade. Okay. Next, gentle traction. When you use the vacuum, okay, when there are no contractions, you may try to release a bit the pressure on the cup. Okay, so traction is only applied in direction of the pelvic curve, in the direction of the pelvic curve. Okay, so non-dominant thumb is placed on the cup to assist. Okay, and as contraction begins, ensure that there's adequate pressure and you pull on the axis of the birth canal. With forceps, traction is also applied in the axis of the birth canal, and the handle is elevated. No, the handle is elevated. Follow the birth canal, axis of the birth canal, and the handle is being elevated. Next, mnemonics. Halt. When do you stop and decide to do cesarean section? When do you actually consider abandoning the procedure and instead do a cesarean section? There's no progress with vacuum. There's no progress after 2 pulls. Okay, delivery is not imminent. No, you don't see any signs of immediate delivery. After 4 contractions, you reassess the method of delivery. The cup popped off 3 times. You have to abandon the procedure and proceed with and instead do cesarean section. It has been 20 minutes since the procedure and still the baby is not delivered. Okay, because the longer the cup is on the head, it can incur more trauma to the baby. Okay, with forceps, you decide to do cesarean section after difficulty or there's failure of proper application. You cannot lock the forceps, then you have to do cesarean section. Failed rotation. Okay, there is no descent during traction, and you have to deliver it by a cesarean section. If it is not imminent, you tried to pull 3 times already, but there was no signs of delivery of the baby, then you have to do cesarean section. Next, if and when there are signs of progression of the descent of the head, although it is not routine to do episiotomy, you may do episiotomy if it is deemed necessary. Okay, selective mediolateral episiotomy can reduce obstetric anal sphincter injury for cases of assisted vaginal delivery. Okay, with the midline, it should be in a right mediolateral incision because with the midline incision, it tends to have risk of a 4th-degree laceration. Okay, you remove the vacuum and the forceps once you have seen the jaw of the baby. Once the jaw is already visible, then you can release the pressure on the vacuum. You can remove the forceps and deliver the baby subsequently. All right. What are the contraindications to vacuum? Inexperienced operator, you don't know how to actually do it, then don't do vacuum delivery. Inability to assess fetal position. The station is very high. The head is not visible in the introitus. Hence, you don't know the position. You cannot identify the flexion point. Then you cannot do vacuum extraction. You are thinking that there could be cephalopelvic disproportion. It is a phased presentation or non-vertex presentation. Then you cannot do vacuum extraction. There's fetal coagulopathy. Okay. And the baby had the recent fetal blood sampling, scalp blood sampling, and you cannot do vacuum extraction. Which one is superior, the vacuum or the forceps? They say with the forceps, there's higher frequency of trauma, of blood loss, because you might incur sulcus tear, no? The tear could be from the vagina all the way near to the cervix. There could be fetal incontinence in patients who had forceps delivery. They say with vacuum, there's neonatal jaundice, lower episiotomy rates. It could be shoulder dystocia and cephalhematoma. But then our data are very, very few only. There's no significant difference whether you use a forceps or a vacuum. Data show that the difference is not very significant. Okay. So now let us proceed with cesarean obstetric procedure, operative procedure, cesarean section. What are the indications? Maternal indications, a prior cesarean delivery, abnormal placentation in the form of a placenta previa per request. But this one, it is debatable because in the recent convention that we had, questionable ang maternal request because we are trying to lessen the incidence of cesarean section rate. And so maternal request, medyo questionable pa ito. No, it's not really outright that when the mother requests, it is granted. Okay, because it might be abused, no? Economically abused. So it is being questioned whether it is ethically right to do cesarean section per request. Okay, you do cesarean section for a classical hysterotomy. The patient had a previous history of uterine rupture and the uterus was repaired. Then on the next delivery, it should be via cesarean section. Unknown previous incision, you don't know if it is a classical, whether your patient had a previous uterine surgery, myomectomy, especially if your patient had a myomectomy, they cannot go into labor, and so you have to do cesarean section. Okay, genital tract obstructive mass. There's mass on the vaginal mass or a cervical mass, then you have to do cesarean section. Your patient had previous cervical procedures resulting to fibrosis of the cervix, and you have to do cesarean section, or permanent cerclage. Your patient have repeated the pregnancy loss and the cervix is weak and they apply a permanent cerclage, then they have to undergo cesarean section. Pelvic deformity, all right? Previous pelvic surgery, HIV infection, outright cesarean section. Your patient has a cardiac or pulmonary disease, you may do cesarean section. Aneurysm, your patient cannot do Valsalva. Okay, so AV malformation, your patient cannot do Valsalva. Okay, or the mother is already having arrest, no, cardiopulmonary arrest, and the baby's still alive, and you want to save the baby, you do right away cesarean section. Okay. Indications: maternal fetal CPD. The pelvis isn't adequate. Of course, you have to do cesarean section. Failed vaginal, operative vaginal delivery, failed vacuum, failed forceps, placenta previa, or abruptio placenta. For the fetal indication of cesarean section, we have non-reassuring fetal status, malpresentation, transverse lie, breech presentation, fetal macrosomia, you have to do cesarean section because you might have dystocia. Okay, congenital anomaly, hydrocephalus, gastric schisis, sacrococcygeal teratoma, you have to do cesarean section. Okay, abnormal fetal status based on ultrasound, poor perfusion to the uterus, from the uterus to the baby, you have to do cesarean section. The patient has a blood dyscrasia, the baby is a blood dyscrasia, and a prior neonatal birth trauma in the previous pregnancy, then you have to do cesarean section. When you talk about cesarean section, we have in the layman, they call it bikini or the transverse incision, abdominal incision. We are talking, let me remind you, we are talking about abdominal incision on the abdomen. We have a transverse incision, or commonly known among the layman as a bikini cut. Okay, it follows the longer lines of the skin tension. It is superior because cosmetically or aesthetically, it is favorable to some patients. Okay, it is, they say it's less cause of pain. Okay, less dehiscence, all right? But when you do this kind of incision, you will have limited access to the upper abdomen because your incision is in the suprapubic area. And so you will have difficulty reaching up to the fundus. Okay? Fluid between the muscle layers, okay, may encounter neurovascular. You might hit some nerves on the maternal abdomen, and once it is cut, there can be impairment. No, there can be paresthesia on the area of the mons pubis, probably because the nerves there are being cut through because of the incision. What is popular among patients, or what we usually do, are the midline vertical incision on the abdomen, maternal abdomen. It provides a quick entry and shortened incision, from the delivery time when you do this kind of incision, less blood loss. Okay, you have access to the upper abdomen. Okay, it will be easier for you to extend the incision because you are already in the midline incision. But then it has poor cosmetic results, and so some patients would still request for a transverse abdominal incision. So this is how a cesarean section is being done, whether you have done a transverse or a midline abdominal incision. This is what happens in the low segment transverse cesarean section. Lower segment of the uterus. Okay, lower segment of the uterus. You identify the bladder flap and you identify the lower uterine segment, and you have to separate the bladder. Okay, you have to separate the bladder. And so as you can see in the picture, there is a catheter, balloon catheter. You have to insert catheter, Foley catheter, so that you will be able, the bladder would not be distended. And so when you do this incision on the abdomen up to the uterus, you will not be able to injure the bladder. Okay, so after that, you will do a uterine incision. You see here the amniotic sac visible, and you have to extend your incision sideways, but you must be using the hand or a blunt abdominal incision, the uterine incision, blunt dissection, or you may use a bandage scissor, but it must be you should be conscious, no? It should be away from the uterines, because if you cut through the uterines, you would be having profuse bleeding. Okay. And then once your incision is adequate, you now deliver the fetal head, the lower uterine segment. Okay, delivery of the head. Once the head is delivered, you deliver first the anterior shoulder and then the posterior shoulder. All right, after delivering of the baby, you have cut the cord. Then now you deliver the placenta. Still the same with the vaginal delivery. You have to have gentle traction on the placenta. Okay, in order for you to incur less bleeding. After that, you have to clean the uterine cavity. You get rid of the remaining placental tissues so that you will not have postpartum bleeding because of the remnants of the placental tissues. It can incur postpartum bleeding. After you have cleaned the uterine cavity, then you start to suture the uterus layer by layer. All right. So the cut edges of the incision are being approximated using a round running, okay, locking suture. All right. So we have to consider with cesarean delivery, it imposes risk. Okay, so when is the timing of cesarean section? You should be sure that you have a mature fetus. Based on the last normal menstrual period, based on an early ultrasound, based on the recent ultrasound, you have to establish first fetal maturity. Perioperative care. The patient may be sedated before the surgery because some patients are anxious, okay? Antacids may be given, all right? You may tilt the mother on the left, okay? To prevent hypotension, especially if the patient has a very big abdomen, fetal macrosomia. Some will, anesthesiologists would request the mother to be tilted on the left in order to prevent hypotension once the baby is delivered. Okay, how do you prevent infection when you do cesarean section? Of course, you have to give prophylactic antibiotic. Okay, in the form of cefazolin 1 gram or clindamycin 600, 1 hour prior to the procedure. Or if the patient is obese, you have to give higher doses in 2 grams, no? Or cefazolin or clindamycin, that's 900 grams. For the safety, you have to, if some of you are nurses here, you have to identify the patient, make markings probably on the site, and complete surgical timeout. Identify the surgeon, identify possible complications in order to prevent it from happening. What are the sources of morbidity in cesarean section? Puerperal infection, especially if the patient had premature rupture of membranes and there's already infection, then it could be a source of morbidity when there's already chorioamnionitis. So it would result to peripheral infection, hemorrhage, thromboembolism, other anesthetic complication, high spinal anesthesia. The patient might go into arrest while doing the procedure in cases of cardiac disease or aneurysm. Okay, the wound might be disrupted after the surgery due to poor hygiene, poor nutrition, and non-compliance to medications. Blood loss during the procedure, hypovolemic shock, or a blood transfusion itself. When do we do classical cesarean section? This time we are talking about uterine incision. A classical cesarean section. Okay, we do this if the bladder is densely adherent and you cannot do a lower segment transverse cesarean section or incision. The bladder is very adherent on the lower segment and you might injure the bladder, then you rather do a classical incision. So from the lower segment going up to the fundus. Okay, other indications. Placenta previa, and the placenta is positioned anterior to the uterus. You must do classical incision. Transverse lie. A transverse lie, it would be easier to deliver the baby if the incision is transverse. Or there is a myoma on the lower uterine segment, then you have to do classical cesarean section. So this is how it is done. After you have opened the abdomen, okay, whether it is a transverse abdominal incision or a midline abdominal incision, coming into the uterus, you will do a classical incision from the lower uterine segment up to the fundus. Then after you have delivered the baby, the same with lower uterine segment incision, you close the uterus layer by layer. All right. So I think this is the last of my slide. Thank you for your kind attention. Have a good day.